Among the management strategies, anticoagulation is the most important step. The next important step would be to control the ventricular rate and prevent tachycardia induced ventricular remodeling. Control of ventricular rate is crucial component of treatment of atrial fibrillation. Rate controlling agents act by increasing the refractoriness of the AV node, so much so they will not conduct all the impulses, or majority of the impulses of the atria are blocked and the heart rate is maintained within reasonable limit. What drugs we use? Beta blockers and calcium channel blockers are the first line agents for rate control. Beta blockers like metoprolol, carvedilol can be used among the calcium channel blockers. We should not use the nifedipine group of drugs. Diltiazem and verapamil, among the two, diltiazem is more suitable. They can be given either intravenously or orally depending on the urgency in the patient. Patients who have reactive obstructive airway disease or reversible obstructive airway disease, that is the asthmatic patients, reactive airway disease, we need to exert caution when we use beta blockers in them. We have to try and achieve a resting heart rate of 80, and with exertion, that is 6-minute walk test, the heart rate should be 110. Digoxin is rarely used as monotherapy for rate control because it will not be useful in patients who have tachycardia. Somewhat useful in patients with heart failure and in LV dysfunction. Suppose the patient is having heart failure and associated LV dysfunction, then probably digoxin as an inotropic agent would be useful. Amiodarone, a class 2A recommendation for rate control. So we don't use amiodarone as the first drug for rate control, it is more for the rhythm control. For rate control we use beta blockers or calcium channel blockers as the first line agents. Again, to re-emphasize, the main drugs are for rate control the beta blockers, the newer generation beta blockers, carvedilol, metoprolol, calcium channel blockers, non-dihydropyrimidine type of calcium channel blockers, not the nifedipines, but the diltiazem and verapamil group, and of course in selected cases who have either evidence of left ventricular dysfunction or heart failure, digoxin can be a rate control drug. Digoxin, remember, is not the choice in all patients, unlike the previous test teachings. For rapid rate control, IV drugs should be used. IV calcium channel blockers like diltiazem, verapamil, or beta blocker metoprolol or esmolol. Diltiazem is preferred because of its least side effects. For patients with increased sympathetic tone, beta blocker would be a preferred choice, particularly esmolol or metoprolol. Atrial fibrillation with heart failure, digoxin will be the choice, not a calcium channel blocker and not a beta blocker. Digoxin has a delayed onset of action, and it cannot be useful in an emergency situation. It is not effective rapidly. Amiodarone is the choice in atrial fibrillation with congestive heart failure and when the blood pressure is falling. Flecainide or amiodarone in atrial fibrillation when there is pre-excitation in the ECG to stop the accessory pathway, to have the antiarrhythmic effect on the accessory pathway. Calcium channel blockers and digoxin are contraindicated in patients with pre-excitation like WPW.